Thank you very much for bringing me back, Frank, to this wonderful meeting and this great debate. Unfortunately, half of my slides have been shown already, so I'll try to say some different words on the same themes and maybe emphasize a few things. Stroke risk is declining in patients with asymptomatic disease. I don't think anybody can debate that, even though someone just tried. But I think you should take a look at this paper from Kansas from last year, where they followed 864 patients with asymptomatic carotid disease for, I think, up to 6 years. And this little bit complex slide shows on the y-axis with blue the cumulative risk of stroke, TIA, and carotid revasc in different groups with different levels of compliance to medical therapy. So those you don't want to treat with medical therapy and you wish to operate, on the far left, they carry a 3.5% risk of stroke, whereas those where you treat them appropriately on the right side, and notice they don't smoke, their blood pressure is under control, LDL is low, and they're on statins. Their combined stroke, TIA, and revasc risk is 0.7%, combined 0.7%. And similarly, in the bioimage study, where we followed 6,000 patients who were all asymptomatic from any cardiovascular disease for up to 3 years, we identified 349 at baseline with an asymptomatic greater than 50% stenosis. And after 3 years, that group experienced 4 strokes, an annual stroke rate of 0.4%. And this is in Americans, not Europeans. So my interpretation is that the risk of TIA, stroke, and revasc becomes extremely low if risk factors are treated appropriately. And progression of stenosis is a sign of insufficient risk factor control and preventive treatment rather than a sign of increased risk of stroke. Yes, we have new guidelines, and yes, in January we published the European guidelines, as you already have heard. And we did right, but rather than having a Class 1A recommendation for surgery in asymptomatic patients, it's a 2A, provided that there is at least one or more imaging characteristics associated with an increased risk and a documented lower than 3% risk of a perioperative stroke. And similarly for CAS, but it's a 2B and not a 2A. And the reason for that distinction was this small meta-analysis that is also published in the same document, which favors endarterectomy for asymptomatic stenosis. And if you look at this complex sheet, you can see that if you're on the asymptomatic, which is the blue side here, and that you have more than one feature, you can go on maybe to an intervention. And some of these data comes from this review paper that was done with our chairman here. And you can see that in these papers we found an accrued annual rate of ipsilateral stroke, which was 3, 4, 5, or 6%. However, and this is the good old story, these data were obtained at a time when patients were not treated as well as they are today. So we can still discuss whether or not this is useful. So for asymptomatic carotid stenosis, the risk is very, very low of stroke, 0.3 to 0.5% per year on average. But there's a very high risk of cardiovascular events, which is probably more important. Therefore, medical management works, and it lowers risk. Endarterectomy or stenting is in general not warranted unless this high plaque can be identified. And that's where we need 3D ultrasound, because as it's asked in my last question, how do we identify them? And using 3D ultrasound, we can do tomography, just like you can do with CT or MRI. The difference is that this is cheap. It's going to be available everywhere, which MRI is not, and MRI is not simple. And by using this methodology to define where the plaque is and where the center is, we were able to show a fantastic reproducibility of a plaque volume assessment in 37 plaques scanned by blinded investigators. And this will allow for much better plaque quantification of volume and morphology. Assessment of degree of stenosis will improve because we will now be able to do the angle compensation in 3D. The examination will be speeded up, and it's going to be easier to perform a good scan. So we have all the opportunities we need to get new, good, valid data. Thank you for your attention.